The case of Mr. A, from non-adherence to shared understanding. Okay, let's jump right into this explainer by exploring a common, yet honestly pretty complex medical puzzle that happens in clinics every single day. We've all dealt with miscommunication, right? But in a healthcare setting, those breakdowns can literally be life-threatening. So today, we're unpacking a really fascinating concept that completely transforms how we fix these interactions.
Why do patients stop taking life-saving medications? Well, when this happens, it's super easy for the medical system to just label a patient as non-adherent. You know, it's a neat, convenient little clinical box. But what if we completely reframe this? What if we look at it not as a patient failure, but as a complex communication puzzle that we need to solve together?
The case of Mr. A, a clinical puzzle.
To really unpack this, we're going to anchor our analysis today on a very specific real-world case study from the Yale office-based medicine curriculum. So here's the situation. Mr. A is a 38-year-old man who recently arrived in the U.S. as a refugee from Afghanistan. He's communicating with his doctor through a video interpreter, and he presents with a blood pressure of 168/96. That is dangerously high. And why? Because he stopped taking his medication months ago. A neighbor warned him the medicine could damage his heart, and well, he prefers traditional herbal remedies anyway. So how do you respond to this without completely damaging trust while still addressing that severe blood pressure?
Competence versus humility, shifting the paradigm.
To solve Mr. A's clinical puzzle, we absolutely have to shift our mindset away from an outdated healthcare framework. Historically, medical education focused heavily on cultural competence. That's the idea that you could memorize a static checklist of a culture's beliefs, kind of neatly packed away in a box. But honestly, this is incredibly limiting. It oversimplifies things and assumes you can somehow master another person's background. The much better approach is cultural humility. It's not a checklist, it's a dynamic, growing mindset based on just ongoing, active curiosity.
First described in a 1998 framework by Tervalon and Marie Garcia, cultural humility essentially asks us to maintain a totally open stance toward each patient's unique experience. It's a lifelong commitment to learning, self-reflection, and, most importantly, acknowledging the inherent power imbalances in that doctor-patient relationship.
Hidden healthcare barriers, beyond the examiner.
Let's step into Mr. A's shoes for a second and use this humble approach to peel back the invisible layers of his story. Because, let's face it, clinic visits do not occur in a vacuum. Think about the last time you felt intimidated in an office. Now multiply that by navigating a completely foreign pharmacy system. Add in a language barrier that requires a video interpreter, the intense, overwhelming stress of finding employment for a displaced family, and the hesitation to question a physician's authority. I mean, these are massive, structural walls standing right in the middle of the exam room. When you view his choices through this specific lens, everything changes. The intimidating maze of the modern hospital system contrasts sharply with the familiar, well-meaning advice of a neighbor. Trusting his neighbor over a highly confusing medical system isn't defiance at all. It is a perfectly rational coping mechanism in a completely unfamiliar environment. Makes perfect sense, right?
The 5 R's framework, a practical toolkit.
Now, theory is great and all, but outpatient visits are heavily time-constrained. How do we actually apply cultural humility in a fast 15-minute visit while tackling high blood pressure? Well, our source material highlights a brilliant 2019 tool for this called the 5 R's. The first R is reflection. Before we even speak, we must notice our own initial frustration with his so-called non-adherence. We have to deliberately check our internal biases and ask ourselves, wait, am I just assuming he doesn't care about his health?
Second is respect. Instead of lecturing him, we genuinely thank Mr. A for sharing his fears. We acknowledge that navigating a new system is incredibly difficult, and we actively invite him to describe the herbal remedies his community uses. Third is regard. This means we maintain a positive, completely non-judgmental tone. We absolutely do not dismiss his traditional practices. Instead, we appreciate that he is actively trying to care for his health based on the information he currently trusts.
Fourth is relevance. We really have to recognize how his specific refugee experience and language barriers impact his daily decisions. It's highly relevant that he might not even know how the U.S. prescription refill system works. That makes herbal tea a much more accessible option for him.
Finally, resilience. Here, we identify his strengths. We build a plan that celebrates his fierce commitment to his family and his active pursuit of care, despite the overwhelming challenges of resettlement. We focus heavily on what he is actually doing right.
The healthcare team approach, professional humility.
So, we've successfully used the 5 R's to understand Mr. A, but reaching a collaborative resolution requires widening our lens beyond just the physician sitting in the room. This introduces a 2024 framework that builds directly on top of cultural humility, called professional humility. It basically asks clinicians to recognize professional hierarchies and the limits of their own specific knowledge. You don't have to be the hero who solves everything yourself. You remain receptive to learning from the patient and, crucially, your colleagues.
To truly help Mr. A, we engage the entire interprofessional team. We bring in nurses for tailored education. We engage pharmacists to address his specific fears about side effects. We involve social workers to help him with the immense logistical burdens of resettlement. Every single slice of the care team is absolutely essential here.
And this team approach leads directly to the pinnacle of patient-centered care, shared decision-making. Instead of dictating treatments from on high, we engage in an open dialogue, collaboratively combining the clinical necessity of lowering his blood pressure with his personal priorities and beliefs.
The collaborative resolution, solving the puzzle.
Let's look at the conclusion of Mr. A's case and see how this all builds into a successful shared outcome. Because the clinician approached him with curiosity rather than judgment, the puzzle gets solved. Mr. A understands the long-term risks and agrees to restart his medication. In return, the team respects his use of traditional remedies. And this is key. The pharmacy team steps in to patiently teach him exactly how to navigate the refill system. He is finally fully supported. A real game changer.
As the research beautifully puts it, cultivating a respectful and collaborative relationship with each individual patient. Honestly, this is a massive relief. It means it's not your job to be a walking encyclopedia of every culture in the world. Your job is simply to cultivate a respectful, curious relationship with a human being sitting right in front of you.
I want to leave you with this provocative question to ponder. What hidden assumptions are you bringing to work? Whether you're in healthcare, education, or really any diverse environment, hopefully the story of Mr. A pushes the concept of cultural humility far beyond the clinic walls and into your everyday interactions. Stay curious, stay humble, and thanks so much for exploring this with me today.